Alright, chapter 27 here, chest and abdominal trauma. As you will notice as we're covering these trauma chapters, a lot of the care is exactly the same. The steps you're going to take is the same. So the chapters themselves are a little bit shorter, the PowerPoints. Once you understand the basics of treating trauma, it's really all the same. So here we go. Obviously, covering chest and abdominal injuries, so we'll start with the chest. So blunt trauma, as we've covered before, it's just a blunt force. It can fracture ribs, the sternum, and the costally rib cartilages. Compression occurs when severe blunt trauma causes the chest to rapidly compress. These are your high mechanism of injury, your traffic accidents, where a patient may come in contact with the steering wheel, the dash, etc. Penetrating objects, bullets, knives, pieces of metal or glass, steel rods, pipes, and other objects. These are definitely things that you want to pay attention to, treat accordingly. The chances of you responding to a penetrating chest injury, it's not that often. You'll typically see it in assault cases or at times during a motor vehicle accident. And these can damage internal organs and impair respiration. You need to have a high level of suspicion for both of those. So closed chest injuries, little diagram there showing broken ribs, nothing's protruding through the skin. You can tell when the ribs are broken, they'll get a flail chest, which we'll cover. But yeah, a lot of the closed chest injuries you may not be able to know. You need to pay attention to the level of mechanism, and just have a high suspicion and monitor vital signs. So paradoxal motion, as you breathe in, your chest, the left and right side will expand and contract evenly, okay? The paradoxal motion, the flail section, which has the 3 or more broken ribs there, it will move oppositely of the other, okay? So on inspiration, the flail section of the chest will actually, like you're breathing out, it'll move in. And then when you expire, it'll move out. So flail chest, fracture of 2 or more consecutive ribs in 2 or more places. The paradoxal motion, again, the flail segment moves opposite to the movement of the remainder of the chest cavities, the uninjured side. So mechanism of injury capable of causing injury. This is your assessment. You're looking for difficulty breathing, hypoxia, pain at the injury site, any bruising, swelling, likely signs of shock and hypoxia, and chest wall muscle contraction. The care, as always, ABCs, treat any live threats, administer O2 if need be. If the patient is not breathing adequately, assist with ventilation with BVM. Follow your local protocols regarding using non-invasive positive pressure ventilations. And the reason it's saying follow local protocols is because of head injuries. It may be a little bit different depending on what protocols you're using. Monitor the patient carefully and watch respiratory rate and depth. So open chest injuries. Difficult to tell what is injured from the entrance wound. Okay. Assume all wounds are life-threatening. Open wounds allow air into the chest, which can be deadly if left untreated. It sets an imbalance in the pressure. Remember, the pressure is needed for breathing, right? That negative and positive pressure is actually what's doing the breathing for you. So you throw that out of whack, you're not going to be breathing adequately. It causes a lung to collapse on the injured side. So a sucking chest wound, I've only seen this once in my career. It's very easy to treat, but it's very distracting from everything else, okay? So the chest cavity is actually open to the atmosphere, causing that change in pressure, right? May or may not be a sucking sound. It all kind of depends on the size of the wound and what's all going on. And they can be gasping for air. So ABC's right, maintain that open airway. You want to seal the wound. Immediately what you want to do is place a gloved hand over the wound until you can apply an occlusive dressing. Okay, and there's special ones out there. Some of them have Vaseline to help stick to the chest, allows the air to escape the chest. Administer high concentration O2, titrate to effect. Care for shock as always, immediate transport is needed, and anytime you have that, you should have ALS en route. I know the book always says consider ALS. Most protocols would have you contact them and get them en route right away. So occlusive and flutter valve dressings. It involves taping the dressing in place and leaving a side or corner unsealed. As the patient inhales, the dressing will seal the wound, so it's not bringing any extra air into the chest cavity. Okay. As it exhales, the free corner or the edge, it acts like a flutter valve, and it releases air that's trapped in the chest cavity. Now, some of the occlusive dressings out there, especially like the Vaseline, you need to constantly monitor that to make sure that the air is allowed to escape. You may have to play with it a little bit, maybe peel back to allow that, okay? So you can see there's the occlusive dressing. It's taped on there. You can use like a saran wrap, out of your kitchen. Some places use tinfoil. It's not recommended. But you can make an occlusive dressing really out of a lot of different things in the ambulance. You can open up a package of gauze and you can use the plastic from that as a dressing. Whatever you have, whatever you can use that's available, do so. So think about it. Does the patient's chest injury need to be treated during the primary assessment? If it's life-threatening, right, you're going to do so. If it's a sucking chest wound, you want that gloved hand over it immediately. You want to prevent air getting trapped into the chest cavity. Does the open chest injury require an occlusive dressing? If it's an open chest injury near the lungs, absolutely. It's preventative. Does the patient's injury necessitate immediate transport to a trauma center? It really depends on that one. Typically, I would say yes, but you're going to monitor your patient. If it's just a simple flesh wound, not that big of a deal. You're gonna gain that with experience. But at the beginning of your career, absolutely go to a trauma center. So injuries within the chest cavity, you can have a pneumothorax. I don't know why they have it listed there twice. Hemothorax, pneumothorax, traumatic asphyxia, cardiac tamponade, and aortic injury and dissection. I have seen all of these in my career, sadly. So, pneumothorax and tension pneumothorax. The pneumothorax is when air enters the chest cavity, possibly causing a collapsed lung. The tension pneumo is a type of pneumothorax where the air that enters the chest cavity is prevented from escaping, and it's just going to build up there. Well, when it does that, it does not allow the lung to expand, even if the lung is not damaged. Okay, and this is where you get your JVD, sometimes your trachea displacement. Patients typically have diminished or absent lung sounds on the affected side. Anytime there's chest trauma, you want to listen to lung sounds, compare side to side. Okay, if you have extremely diminished on one side or completely absent, definitely get history from the patient if able to. Make sure there's not a medical explanation as to why that is. But I have a high suspicion of a pneumo or a tension pneumo. Hemothorax. Remember, hemo's blood. So the chest cavity fills with blood from internal injuries. The hemopneumothorax is it fills with both blood and air. And, in pre-hospital setting, it's going to be tough to differentiate what is causing the issue. Here's a little diagram showing the pneumothorax, hemothorax, and the hemopneumo. Okay. Traumatic asphyxia. It's a sudden compression of chest, forcing blood out of the organs and rupturing blood vessels. You'll see this quite a bit in collapse, trench collapse, grain bin, people that are trapped in a grain bin. The neck and face are darker color than the rest of the body. That's because of all the ruptured blood vessels, and with the blood being forced out of the organs, it goes up. May cause bulging eyes, distended neck veins, and broken blood vessels in the face. Cardiac tamponade, direct injury to heart, causing blood to flow into the precordial sac around the heart. The pericardium is a tough sac that rarely leaks, so increased pressure on our heart so chambers cannot fill. If left untreated, eventually the blood will fill up enough to where not only can the chambers not fill, your heart will completely stop. Blood backs up into the veins, usually a result of penetrating trauma. And you're going to see distended neck veins, that JBD, shock, and narrowed pulse pressure. Aortic injury and dissection, you'll see this a lot in T-bone accidents at high rates of speed. Aorta is the largest blood vessel in the body. Penetrating trauma can cause direct damage. Blunt trauma can sever or tear the aorta. Damage can cause high pressure bleeding, often fatal. And it's fatal very quickly when this happens. Now you think about how your heart sits in your body. So in a T-bone accident, think about the force on the body and what's going to happen. Your body's traveling one direction. You get hit from the side. Okay, so your body naturally goes to the side that was hit. And what that causes is the shearing of the aorta at times in the body. And they will bleed out most likely before you ever can make a scene. The patient will complain of pain in chest, usually sharp, abdomen, or the back. They're going to have signs of shock. They're going to be hypotensive. Differences in pulse or blood pressure between the right and the left arm, or differences in pulses between the arms and legs or the legs themselves. Commotio cordis, uncommon condition. Trauma to chest when the heart is vulnerable. Okay, so when your heart is beating, there is just a millisecond of where if there's blunt force trauma to the chest, it will actually stop your heart. If an untreated patient will go into VVIB, treat like a VVIB patient. CPR, early defibrillation is best. So abdominal injuries here can be open or closed. Internal bleeding can be severe if organs or blood vessels are lacerated or ruptured. Think back to the spleen and the liver. They're very vascular, full of blood. Okay, so if those are lacerated or injured, they can bleed out very quickly. Serious painful reactions if hollow organs are ruptured. Remember, you have your solid and your hollow organs. And, depending on what is injured is how they're going to present pain-wise. Evisceration may occur. That's where the organs are protruding through the wound opening. This is your intestines and all that sticking out. Little fake picture there. If you get on the internet, you can see actual pictures of what this looks like. Yeah, pretty gross actually. So patient assessment, you're going to start with your ABCs as always. The pain initially mild but rapidly becoming intolerable. It's just going to keep increasing. A lot of times they're going to have cramps. Nausea is very common. They're going to be very weak, very thirsty. Obvious lacerations and puncture wounds to the abdomen. You're going to have wounds to the pelvis, middle and lower back. Can also affect the abdomen. Indications of blunt force trauma, especially motor vehicle accidents. Indications of developing shock. You're looking for that drop in blood pressure. Coughing or vomiting blood. Rigid and or tender abdomen. Distended abdomen. Patient tries to lie very still. A lot of times they may have their position of comfort may be their knees slightly bent. Stay alert for vomiting. The reason for it, you want to keep that airway open. Be prepared to suction if needed or to turn the patient on their side. You want to keep that airway open. Place patient on back with the legs flexed at knees to reduce tension on abdominal muscles. Again, that's probably going to be their position of comfort. Administer high concentration oxygen, titrate to effect, and care for shock. Give nothing to the patient by mouth. No water, no food, which we don't carry it on the ambulance anyways. Continuously monitor vital signs. This is going to be every 5 minutes at the minimum. Again, on serious calls, a lot of times I will cut that down to every 2 minutes. Transport immediately. It's going to be a load and go. Have ALS en route and get to the nearest trauma center. So some additional steps. Control external bleeding and dress all wounds. Do not touch or replace eviscerated organs. Apply sterile dressing, moistened with sterile water over the wound site. Not a dry dressing. It needs to be moistened. It needs to be wet. For large evisceration, maintain warmth by placing layers of bulky dressing over occlusive dressing. Do not remove any impaled objects, as always. Stabilize with bulky dressing, bandaged in place. Leave patient's legs in position found to avoid muscular movement that may move an impaled object. So critical thinking here. You're caring for a patient who was shot in the chest with a nail gun. You applied an occlusive dressing around the wound. The patient is suddenly deteriorating. He's having extreme difficulty breathing and his color has worsened. Breath sounds have become almost totally absent on the side with the impaled nail. What complication might you suspect is causing his worsening condition? How could this be corrected? Now think about it. You have an open chest wound because of the nail. It doesn't really say if it's still in there or not. So with the application of there's some sirens there if you guys can hear that. With the application of the occlusive dressing, it may not be allowing the air to escape. Remember how I said before you may have to peel back a corner or make sure that it's allowing the air to escape. Most likely this is what's happening. The decreased breath sounds. You're probably going to see some JVD going on and maybe pushing that trachea. So adjust the occlusive dressing. And if that is not working well, you should already have ALS en route, but they may have to do a needle decompression on the patient, which is pretty cool.